Welcome everybody to one more edition of Oncology Beyond the Obvious. And before I introduce my co-program director and interviewee for today, let me just share you some tidbits about what has happened in OBTO. Initially, whenever we call a person, and of course he is a senior person with a lot of original work, when we say that we would like to interview, they said, yeah, no problem. There is absolutely no issue. And then when we say that we are going to do the interview exclusively on a single manuscript, that is when the eyes suddenly open. And then they start thinking. And so much so that our preparations for any session of OBTO requires a complete, full rehearsal of the recording with the person who is being interviewed. So just as we spend a lot of time, the person who is being interviewed also has a lot of preparation and does a lot of time devoted to this, and therefore this actually quality is so much better. The biggest form of flattery is somebody starts imitating it, and as you will have noticed, some people are also doing a similar academic session. Unfortunately, they don't devote as much time as we do in the preparation, in the background work, and therefore they may not be as successful as we are. But really, the biggest gratification that Amish and I have is that people start contacting us and saying that our association, our society would also like to be jointly providing OBTO, and therefore some of you may have got a message that young medical oncologist program of ISMPO is also now propagating OBTO. And I think we must thank each one of you for the devotion that you have given, for the active participation, and also for the interaction that happens during the live meeting. This is what is the heart and essence of OBTO, and we continue and we will continue to innovate as we move forward. So first, I introduce to you Dr. Amish Vora, who, as you all know, a TMH alumni, and he has also done his studies in AIMS, New Delhi. Now he runs the most successful boutique daycare center, which is Hope Oncocare, and he is the brain behind OB2O. I am only hanging around and riding along with him to get all the accolades. So Amish today is going to introduce and interview Dr. Sudeep Gupta. Dr. Sudeep Gupta is a very senior medical oncologist of international repute. So I don't really have to say much, but as part of the Department of Medical Oncology at Tata Hospital and subsequently as director of ACTRAC, he has really taken things to a next level. And many of us are in awe of the way he can dissect out as well as interpret statistics, which is so very important to know the value, the true value of any publication that we have. So I don't want to waste too much time in introducing Dr. Sudeep Gupta further, because he is a stalwart that all of us know. And I will pass on to Amish to start the interview with this Dr. Sudeep Gupta as the first part of today's OBTO. Over to you, Amish.
Thank you, sir. And as sir said, but everyone who has worked with Parikh sir knows very well that his immense support becomes the skeleton of the body, and without that, the body does not function. In fact, last time also in OBTO, I mentioned that Parikh sir and myself, we keep on discussing manuscripts after manuscript till both of us feel that, yes, this is the right paper for next OBTO. In addition to that, how to do the things, how to have the finer nuances at every single point, Parikh sir always supports me. So, sir, without you, I'm nowhere. As I said that, I think OBTO is going to new horizons. Congratulations to you, sir. And everyone who has supported OBTO. In fact, Sudeep is a very, very big supporter of OPO, and we'll discuss in that in the interview. But before we start the interview with Dr. Sudeep Gupta, I, as a customary thing, I like to present few slides on the paper what we are discussing. So the
Amish, I forgot to mention that we should thank our sponsor. Without that, it's not possible to do such an intense academic activity. And today's sponsors are AstraZeneca. Back to you, Amish.
Yes, sir. Thank you so much. So today we are discussing a meta-analysis, and that meta-analysis is PARP inhibitor in the first line maintenance in ovarian cancer. Next slide, please. Before we go on to the paper, many people are asking, where do we get the previous OBTO's recording? And all sessions are available online on YouTube channel of Kavina Creations. I must thank Kavina Creations here because there are many a times where Kavina Creations have done a complete selfless job with a equal enthusiasm and a great dedication, and I must salute the entire Kavina Creations team for that. Next slide, please. So these are the papers which we are discussing today. The first on the top, the title is Maintenance Therapy with PARP Inhibitor in Patients with Newly Diagnosed Advanced Epithelial Ovarian Cancer, Individual Patient Data and Trial Level Meta-Analysis. And it's my pride. With pride, I say that this is an Indian paper by Indian authors and the TMH group. So Dr. Seema Gulia, Dr. Kannan, Dr. Jaya Ghosh, Dr. Rath, Dr. Amita Maheshwari, and Dr. Sudeep Gupta are the authors. And Dr. Gulia and Dr. Kannan are the joint co-first authors, and that is what we are very happy. We have both of them joining us as panelists today, so we will hear more from them as well as from Sudeep. When this first report was submitted, Athena mono trial results were not out. So when the results were out, the authors wrote to the same journal in correspondence, and they updated their results and put forth as a proper complete meta-analysis of all the studies. And that's why I have put two papers. Next slide, please. To be eligible for including in this meta-analysis, the trial had to be randomized and compare PARP inhibitor with placebo as maintenance therapy after completion of first-line platinum-based treatment in patients with stage 3 or 4 epithelial ovarian or primary peritoneal or fallopian tube cancers. Next slide, please. So how did they do? The authors searched PubMed, Embase, Cochrane Library. They also saw the abstracts and meeting presentations of major oncology conferences, including ASCO, ESMO, and GOG. After that, they did the search. Next slide, please. So there are 5 trials which were selected for final inclusion of meta-analysis, including both the papers. One is Paula-1, where olaparib with bevacizumab was seen. Second is Solo-1, where olaparib in germline BRCA1, BRCA2 mutation. Prima study, where niraparib in again the same. Velia, veliparib study, and Athena mono is a rucaparib study. Next slide, please. So data extraction was independently done by 2 joint authors, that is Dr. Gulia and Dr. Kannan. And if there were disagreements, it was resolved by Dr. Sudeep Gupta. Information which was extracted from each selected trial at individual patient basis is authors, publication year, number of patients in the experimental and the control arms, number of patients of germline and somatic BRCA mutation both. In addition to that, HRD status also was seen and different cutoff score, and that Sudeep and Dr. Sahoo will cover in that. In addition to this, their primary endpoint was PFS. So the hazard ratio for PFS and 95% confidence interval in the whole study population and in subgroup was seen. Toxicity, quality of life, time to first subsequent therapy, and PFS2 also was seen. Next slide, please. There were two arms to it. Basically, extracted IPD for the whole study population was taken by 3, followed by Athena. So 4 studies, that is Prima, Paola, Velia, and Athena. Solo 1, because it was only germline, the authors were, it was very nice way of doing. They did compare the subgroup of germline BRCA 1 and 2 from these 4 studies and compared with Solo 1. So Solo 1 was not taken as a whole study population, only 4 trials were taken. Next slide, please. This slide is little not visible, but the arrows which I have put, I wanted to show that whenever there is a BRCA positive, either germline or somatic, the hazard ratio was around 0.3. And wherever there was an HRD without BRCA, the hazard ratio was 0.5 to 0.55. Next slide, please. It's in favor of PARP inhibitors. So this was excluding Solo 1. This was all the 3 trials put together in favor of PARP inhibitor. Hazard ratio was 0.67. Next slide, please. If you see the individual 4 subgroups, the first subgroup on my right hand side in the blue box, I have written the germline or somatic BRCA mutation. The hazard ratio, as I mentioned, was 0.38 in favor of PARP inhibitor. If you follow HRD positive and BRCA positive, the hazard ratio of 0.45. Next slide, please. HRD positive and BRCA negative, again, all the 3 trials put together, and then 4th trial included, hazard ratio of somewhere 0.5. The last group, which I'm sure Sudeep will delve into it when I ask him that question about HRD negative, the hazard ratio was 0.9. And if you can see, the curves are matching together. Next slide, please. These are the 4 subgroups in the forest plot, and Athena is included in that. And this shows that all the 4 trials said that PARP inhibitors work in this particular setting. Next slide, please. So conclusion by authors is I would leave to Dr. Sudeep, Dr. Kannan, and Dr. Gulia when Dr. Sahoo also discusses in panel discussion. With that, I would say that let us start the interview with Sudeep, and we see. Sudeep. Thank you so much, Sudeep, for always being on this platform in spite of your busy schedule. I keep haunting you, I keep troubling you, and you are always kind enough to find time and come on OBTO platform. Not only that, you always encouraged us, and you have always given the positive feedback. At the same time, something better to do, and I really like that. Please continue doing that. But as of today, welcome on this platform again, Sudeep.
Thank you very much, Amish. I love to be haunted by you for the OBTO. And thank you very much to Dr. Parikh and yourself for the opportunity and the privilege to participate. And as I have said earlier, OBTO has made a mark for itself, and it is a distinctive program, and I hope to participate in many more of your sessions in the future as well. Thank you very much for inviting me.
Thank you, Sudeep. And let's go on to our first question. But before our first question, I think this is the year of meta-analysis, or 2 years of meta-analysis. I think your previous meta-analysis of 6 months versus 12 months of trastuzumab has given confidence to many of us to modify our practice based on that meta-analysis. And today we are discussing another landmark meta-analysis, which I'm sure will help us in day-to-day life to take decisions in a better way. So with that, let me ask you first question, Sudeep. Sudeep, in this meta-analysis, there are 5 papers which are being meta-analyzed. Solo 1, Paola 1, Prima, Velia, and Athena. If I understand correctly, all 5 were positive trials. In addition to this, in your reference, you have put that there are 2 other meta-analyses done on this PARP inhibitor in the first-line ovarian maintenance, and both the meta-analyses have concluded exactly the same, that PARP inhibitor is beneficial in this subset of patients. In addition to that, I came across March 2022, there is a network meta-analysis which also concludes the same. So I just wanted to ask you, why did you embark on this journey of this particular meta-analysis when we have so much of positive results from everywhere? Were you suspecting something different or expecting something different?
So thank you for that excellent question. You are absolutely correct that all the 5 studies are in the main positive for the benefit of PARP inhibitors as first-line treatment in ovarian cancer. You are also right that the 2 previous meta-analyses, which were trial-level meta-analyses, have also concluded that PARP inhibitors are beneficial with respect to progression-free survival. What is different about our analysis is that it is an individual patient data meta-analysis. So we have pioneered and to some extent honed our skills in extracting individual time events from published survival curves. And what that allows us to do is 2 things. First, to be able to give some measure of absolute effects or absolute benefits of treatments, in this case PARP inhibitors versus placebo, for the overall trial population. But more importantly, we have been able to cull out subgroups of particular interest where PARP inhibitors may be very useful or not useful at all. And not only have we combined the hazard ratios for these subgroups, but have also given absolute measures of progression-free survival benefit for each of these subgroups. And we believe that our meta-analysis, unlike the previous ones, will help both clinicians and patients to arrive at the right decision and be able to undertake decision-making based on real magnitudes of benefit.
That's perfect, Sudeep. So I think I'm sure we will have one more OBTO where you will teach us how to conduct a meta-analysis and how to read a meta-analysis, but it is beyond the purview for today. So I'll move to the second question, Sudeep. And this was discussed in the first OBTO and subsequent OBTO also. Your primary endpoint of meta-analysis is PFS or progression-free survival. So once and for all, I am asking Dr. Sudeep Gupta that PFS is a good primary endpoint for practice changing in day-to-day life. Am I right in that, Sudeep?
So yes, the short answer to your question is that you are right. Progression-free survival or disease-free survival in the appropriate context and of sufficient magnitude are by themselves useful endpoints in deciding or in decisions regarding treatment in patients, and they are sufficient to change practice. But we must be cognizant of the fact that both progression-free and disease-free survival are actually surrogates for the actual endpoint, which is overall survival, and which is why PFS or DFS benefits of sufficient magnitude are what we are looking at, which should be not only statistically significant, but also clinically meaningful in the eyes of the large majority of clinicians who will practice that treatment.
So when Sudeep, you say sufficient, help me understand according to you, what is sufficient in terms of hazard ratio and absolute benefit? Is hazard ratio of 0.5 sufficient, 0.6 sufficient, or anything above 0.7 is not sufficient, or absolute benefit of say 5 months versus 10 months versus 15 months? If we talk of ovarian cancer, what would be that sufficient according to you?
So in terms of first-line treatment of ovarian cancer and talking of an endpoint like progression-free survival, we know that the control arm outcome in terms of PFS with the usual treatment of chemotherapy and surgery ranges anywhere between about 12 to 18 months, depending on the kind of patients that are reported or analyzed in a particular study. So I would suspect that in this particular context, progression-free survival benefits of absolute magnitude of more than or equal to about 9 to 12 months would be reasonably strong for most clinicians to consider changing their practice, or at least strongly considering that treatment. But on the other hand, progression-free survival benefits of only small magnitude, such as 1 month or 2 months or 3 months, are unlikely to translate into overall survival benefit. Having said that, we must understand that there are some peculiar trials, and some of them have been immune checkpoint inhibitor-based trials in some other diseases, not ovarian cancer, and some studies of first-line or second-line surgical treatments, such as interval cytoreduction or secondary cytoreduction, where actually smaller magnitudes of PFS benefits have translated into larger OS benefits, but that is neither the rule nor the norm with most drug treatments. So I would, the short answer to your question is that hazard ratios of PFS of about 0.5 or lower and absolute survival PFS survival benefits of about 9 to 12 months or larger would be something that would be strongly considered by most clinicians.
Understood. Thank you, Sudeep. So what I understood, that hazard ratio alone may not be sufficient. It is the hazard ratio with the absolute benefit in the clinical context is where the PFS can be taken as a good primary endpoint to consider your practice changing. Thank you so much, Sudeep. Sudeep, one more clarification like that. This particular 5 papers and your meta-analysis have used germline or somatic BRCA mutation. It has used HRD with or without BRCA. So we have basically the 3 biomarkers, and we know that almost 50% of patients will have either of these 3 biomarkers. So we are talking of 1 in 2 patients eligible for PARP inhibitor. According to Dr. Sudeep Gupta, are these reliable biomarkers, or are there any caveats in that which we should be aware of?
With respect to BRCA mutations, both germline and somatic, as well as homologous recombination deficiency, I think they are reasonably well validated and robust biomarkers based on which we can decide to treat or not to treat with PARP inhibitor. So my short answer to your question would be that yes, these are reliable biomarkers in first-line ovarian cancer.
Perfect. So we talked about PFS and we talked about biomarkers also. I think both we face every day in clinics. Very helpful. Sudeep, little bit, I'll talk about the methodology in your meta-analysis. And I'm quoting 3 lines from your paper, which says, advantage of extracted IPD analysis include ability to estimate absolute difference in survival proportions and better analysis of subgroup data. So I'm a little confused here, Sudeep, because when I was going through these papers, in Velia, in this meta-analysis from the Velia study, you have excluded one arm completely. In Paula 1, they have used bevacizumab in addition to PARP inhibitor. Solo 1 speaks only of germline mutation, while Paula 1 speaks of somatic mutation. Prima study has reported HRD positive subgroup with BRCA negative and BRCA positive both, while Velia has not given any subgroup like that. You have a different endpoints in follow-up, different cutoffs of HRD, and on top of that, randomization in Athena was 4:1. Can't there be more heterogeneity? And how do we then sort of analyze these subgroups which are so heterogeneous, according to me, Sudeep?
Yeah, so I think you have touched upon an important or 2 important points. So there are actually 2 questions in your single question. The first question was about methodology and how is extracted individual patient data analysis useful. And we made the point that they can give you absolute effects in terms of survival as well as subgroup analysis. So when we said that extracted IPT is a very useful methodology, we meant in comparison to trial level meta-analysis of the kind that two previous papers have published. And we always want to know not only the hazard ratio of 0.6 or 0.4 or 0.52, but we also want to know 12.8 months versus 21.2 months. So this 12.8 months versus 21.2 months cannot come from a trial level meta-analysis. It can only come from an individual patient data meta-analysis. So that is why I meant to say, or we meant to say, that extracted IPT is a useful technology, and actually extracted individual patient data meta-analysis is nothing but an individual patient data meta-analysis without having to ask the individual investigators for their raw data. We just extract that raw data with exquisite accuracy from published survival curves. And my colleagues, Sadhna Kannan, who's a statistician at ACTREC, and Seema Gulia, who is my colleague from medical oncology at TMC, will have the occasion to perhaps explain in a little more detail how we did that. But suffice to say here that the extraction of individual patient survival times is possible with the methodology that we have sort of gained a little bit of mastery over with exquisite accuracy. Now, your second part of your question was, is it right to combine the studies that have so much of heterogeneity? And let me first say that yes, there is heterogeneity, and you have exactly pointed out the themes of heterogeneity that exist in terms of treatments, in terms of follow-up durations, in terms of the randomization ratios, etc. So you are right, but because the trials were heterogeneous, we had to take a call as to what can be combined and what cannot be combined. So for example, you mentioned one arm of the VALIA study where the PARP inhibitor veliparib was given only with chemotherapy but not as maintenance treatment. So here our overall analysis and the meta-analysis is designed to figure out whether maintenance PARP inhibition after first-line chemotherapy is a useful strategy or not. Now, in that scenario, choosing to include an arm that did not include maintenance PARP inhibition but only gave it during the time of chemotherapy would not have been appropriate, because that would have gone against the very grain of that or the theme of our meta-analysis. But there are other kinds of heterogeneity. For example, one of the studies, Paola, has used bevacizumab in both arms of the study. Now, bevacizumab is one treatment in first-line ovarian cancer, which is either used or not used. People prefer it or don't prefer to use it. But so long as this variable, for example, here the use of bevacizumab is equally distributed between the two arms of that study, I think, or all of us would agree that those two arms can be combined in a meta-analysis with corresponding arms of the other trials and are likely to give us reliable results. So the short answer to your question is that yes, there is heterogeneity. Some kind of heterogeneity is not acceptable. So for example, that led us to exclude one arm of one of the studies. But other kinds of heterogeneity we can live with and is even useful when we do meta-analysis. And so therefore we have the summary results. You also mentioned very correctly that SOLO-1 solely has BRCA mutated patients. So which is why if you look at our meta-analysis, SOLO-1 is not combined with the whole study populations of other trials. It is only combined with the BRCA positive subgroup of other trials. So we have tried to minimize heterogeneity as far as possible, and I believe that our results are reasonably useful for clinical decision making.
Perfect, Sudeep. I just did the perfect answer to my confusing question, as always, and I understand that absolutely correctly. So let's move on to results, Sudeep. And before we jump on to the primary endpoint, I wanted to rack your brain about one question. you have tried to see the impact of PARP inhibitor in this population in terms of age, performance status, and residual disease after surgery. I think residual disease after surgery is one of the most important endpoint in clinical practice, if I understand correctly, in the lifespan of ovarian cancer patient. And your study, your meta-analysis have found that the PARP inhibitor works equally well, irrespective of the differences in this age, performance status, and even if you have a macro residual disease after surgery. Now, when we say this, I wonder what is this obsession of looking only at a platinum sensitive patients or platinum responsive patients. For example, if I have given paclicarbo to one of my patients have not responded, I gave lipodox to that patient responded to lipodox. And if the patient is BRCA mutated positive, should I be offering olaparib to this patient or any other PARP inhibitor for that matter?
So your question is, so you started your question with age and residual disease, and then you came to platinum sensitivity versus resistance. And then you suggested a scenario where a patient with BRCA mutation is not responsive to platinum chemotherapy, but is responsive to a single agent non-platinum treatment.
Right.
I mean, this, first of all, this scenario is a little bit uncommon, where a patient with a BRCA mutation would not be responsive to first-line platinum treatment, but would be responsive to something like liposomal doxorubicin. And this question of whether to use PARP inhibition in such a patient or not cannot be answered from our meta-analysis, or for that matter, from any of the component trials of our meta-analysis, because such patients were not included in that study. But outside of the analysis, if you are asking me whether one can choose to treat such patients with a PARP inhibitor or not, my guess is that if they did show some sensitivity to a drug like liposomal doxorubicin, one could possibly give them a treatment with PARP inhibitor to see if it can maintain that response. The reason why most studies have not included patients, or that platinum sensitivity is used as a surrogate for PARP inhibitor benefit, is because they work by the same mechanism of DNA damage response. So, I mean, it makes logical sense that if a tumor is non-responsive to platinum chemotherapy, it is highly unlikely to be responsive or benefit from PARP inhibition. But in the scenario that you mentioned, maybe perhaps we can use PARP inhibition if a patient does respond to liposomal doxorubicin.
Unless until we have the trial, we can't possibly conclude this statement. But I have a strong feeling that if PARP inhibitor can make an impact with a macrovascular residual disease also, macroscopic residual disease also, it should work in other scenario also. This is what my gut feeling is, Sudeep. But you are right. Till the time we have the randomization between carboplatin alone versus PARP inhibitor, we will not get that answer. I'm sure about that. So coming to the main results, and Sudeep, we have 10 more minutes. The primary endpoint in your meta-analysis, you have divided into 4 groups, Sudeep. The first group is BRCA positive patients, whether somatic or germline. And the best result is in that group, 45.7 months versus 17.7 months. The second group is HRD positive, BRCA positive, where you have 34.7 versus 17.9 months. This is the second best scenario. Third is HRD positive, but BRCA negative. And you have 22.3 months versus 13.1 months. And the last is HRD negative, where you have 15 months versus 13.1 months. 1.9 month of absolute benefit. I'm not going to talk about hazard ratio there. So Sudeep, before we go on to PARP inhibitor and the subgroup, are you okay with the results of placebo arm, that they are exactly behaving like the way they will behave in our any of the garden variety CA ovary patients who are treated with chemotherapy and surgery alone?
Yes, I think so. You have very nicely summarized the results of our analysis. And if one for a moment forgets the PARP inhibitor arms of these studies, you see that the prognosis improves from 12 months in patients who are HRD negative, BRCA negative, to about 18 months when BRCA is positive. And that is exactly what has been reported by many studies, including the famous Australian study that was reported in JCO about 8 or 10 years ago, that BRCA positivity is a marker of platinum responsiveness and of improved prognosis in patients with ovarian cancer. So I think this 12 to 18 month PFS in the control arm of these studies, I think very well fits in with what we observe clinically and with our experience, as well as what has been reported by others.
So just to complete that and take home, New England Journal of Medicine in 2010 had published a paper, randomized control trial of neoadjuvant chemotherapy versus upfront surgery in ovarian cancer. There the PFS in both the arms was 12 months, which is in this study, HRD negative patients, placebo arm is 13 months. So what I understand, Sudeep, what you are trying to say that BRCA, as the HRD positivity and BRCA positivity is there, patients would relapse later compared to those who are HRD negative, even in absence of PARP inhibitors. Is that correct?
Yes, that's absolutely correct. Yes.
Perfect.
Yes.
So BRCA is a prognostic marker also. That is what I understood. Perfectly fine. Sudeep, I just narrated the figures, but we are interested to know the inference of this PFS in the 4 subgroups from your mouth, Sudeep.
So let me just amend that to say that the actual subgroups of interest are 3, and the HRD positive, including BRCA positive, can be kept aside because anyways, it is both. I mean, BRCA positivity does mean HRD positivity. Correct. So the 3 groups of interest actually are HRD, the 3 groups of interest are BRCA positive. The second one is HRD positive but BRCA negative. And the third one is HRD negative and BRCA negative. So in the first group there, where it is BRCA positive, either somatic or germline, the absolute PFS benefit is 28 months. In the second group, where it is HRD positive but BRCA negative, the absolute survival benefit is about 9 months. And in the third group, where it is HRD negative and BRCA negative, the PFS benefit is about 2 months. So you can see the clear gradient of it is actually biology at work. It is, how deficient the cells are in repairing their DNA. And the more deficient they are in repairing their DNA, the greater the benefit from a synthetically lethal mechanism like PARP inhibition. So I think that is the heart and the meat of our analysis, wherein we suggest that patients who have BRCA positivity, either germline or somatic, benefit the most from maintenance PARP inhibition first-line ovarian cancer. Patients with HRD positivity but BRCA negativity, which means HRD positivity by some other mechanisms, still benefit from PARP inhibition. It is about 9 months, which is not 28 months, but which is still something that most of us will consider clinically worthwhile. But I think most of us will also agree that a PFS benefit of 2 months in the first-line treatment of ovarian cancer and in a disease that has such a long natural history is unlikely to be clinically meaningful.
Understood. So, Sudeep, I want you to reiterate this again after I give you some information which you already know. Niraparib is approved in all comers, and Rucaparib, based on Athena mono study, has applied in EU and FDA for all comers. In fact, rucaparib, they have said, irrespective of biomarker status, rucaparib works as first-line maintenance in all patients. So Sudeep, again, your take-home message to people, this is my last question to you, and also the sequence of testing which we should do in our OPD in a day-to-day level.
So thank you. Those are two questions. The first bit is what is my take on use of PARP inhibition as maintenance first-line treatment in all comers, and that all comers also includes HRD negative, BRCA negative. My unequivocal, clear, unambiguous answer is that I believe that PARP inhibitors are not useful as first-line maintenance treatment in patients who are both HRD negative and BRCA negative. And my unequivocal, clear answer also is that they are definitely useful in patients who are BRCA positive, either somatic or germline, and they are likely beneficial in patients who are HRD positive but BRCA negative. The second part of your question is the testing strategy. The problem, at least with me in Tata Memorial Center and many of us, is that we do not have a reliable, well-validated HRD test that is easily accessible to us and is also inexpensive or at least affordable for most of our patients. So in the absence of a good HRD test that is easily accessible, the second and the third category, which is HRD positive, BRCA negative, and the last category, HRD negative, BRCA negative, cannot be reliably be sort of segregated. But if cost was not a concern, and if I had access to a reliable HRD test, then my testing strategy would be to perform the HRD first. And if HRD was positive, that by itself would be sufficient to indicate benefit from first-line maintenance BRCA treatment. And if HRD was positive, I would then also perform in that subgroup of patients germline BRCA testing for reasons of counseling and familial predisposition, etc., and so on. But in the absence of access to a reliable and relatively affordable HRD test, my current testing strategy is germline BRCA followed by somatic BRCA, and in very, very few patients, then the HRD test. So that's how I do it.
So Sudeep, just to conclude, what you are saying is two big messages which I got here. One, start testing HRD in your patients, and the sequence is first is HRD if patient can afford and if you have a reliable testing. If HRD is negative, do not consider offering PARP inhibitor to your patients. If HRD is positive, consider offering them PARP inhibitors based on the current scenario. You need not do BRCA further for offering PARP inhibitors, but you do germline BRCA in those patients for familial or genetic counseling. And if the HRD is negative, and if the HRD is not available, then you go for germline and BRCA, somatic BRCA mutation. Is the message crystal clear, Sudeep?
It couldn't have been clearer. That is absolutely exactly what I think. And I don't know whether you agree with it or not, but that is exactly what I think, how it should be done.
Sudeep, I think, all of us look at your critical analysis of whether it is a meta-analysis, whether it is RCT, whether it is a simple paper or a simple lecture. You normally do not speak anything against or for unless and until you have a proper justification. So every word spoken from you, at least I take it as, quote unquote truth. And we want to continue that, Sudeep. Thank you so much, Sudeep, for, again, I cannot say more thanks to you. You always take out your time and take part in OBTO. We want you to continue doing that. And with that, I pass it on to Parikh sir for taking this proceedings further. Thank you so much, Sudeep.
Thank you very much, Amish, for your kind words, and the pleasure is always mine. I love participating in OBTO, and I hope to do so in the future as well if you invite me. Thank you so much.
Thank you very much, Sudeep and Amish. Now we move on to the panel discussion, and our moderator is none other than Dr. T P Sahoo. He is a common and a very useful and frequent part of oncology beyond the obvious. And for today's program, instead of calling him the moderator, with Tarini's permission, I will call him the devil's advocate, because his job is really to find faults and look at the whole picture from the other side of the coin. His panelists are all very senior people. Dr. Ajay Bafna, senior medical oncologist from Jaipur. Dr. S. P. Somashekhar, senior surgical oncologist from Bangalore. Dr. Ajay Yadav, also from Jaipur, but from a different institution where I work. Dr. Seema Gulia, who is here because she has a very vital role. She is the first author of the paper that we have just discussed. Dr. Prasad Ganeshan, again, thank you very much for joining us. Dr. Sudeep Gupta, Dr. Prasad Narayana, and hopefully Dr. Vamsi Krishna is also logged in by this time. So, Sahu, can I pass on the baton to you?
Just a minute. Good evening, sir. And good evening, everyone. I am audible?
Yes, yes, we can hear you.
Yeah.
And your screen is also, your slides are also very well seen.
Yeah. So I think we have also Dr. Kannan.
Correct.
Yeah. So there's an echo somewhere.
At your end, I think.
So if you have logged in from two devices, one you will have to.
Yeah.
Already muted. I've already muted.
No, you will have to.
Someone else is logging in for two devices. Okay, let's carry on. Hello.
Yeah, sir, we can hear you better now, sir.
Yeah. So let's now move on. And I think finding fault with such a perfect publication would be a very difficult job. But let's be fair to the authors also, and let's find out what best can come out of this. The data is very clear, and Dr. Sudeep being there has made it much more clearer, and Dr. Amish has put the ball rolling for all of us. So I'll go to the first slide. Yeah. So meta-analysis is what we are talking of, and it was aggregate, trial level meta-analysis, IPD, the individual patient data, the conventional way, and the extracted version. So do we have Dr. Kannan here? Before Dr. Kannan comes in, I would like to go to my clinicians first. Dr. Ajay Bafna first. Dr. Bafna. Yeah. Hello.
So from this paper, it was very clear that
I have a different question from you. So
okay.
So I would like you to tell me that the IPD, the conventional way versus the extracted version. What do you make of this? And what we have been conventionally looking at the individual patient data from the conventional way, where the whole data set is collected from the authors from all across the trials, which is selected, and you have the raw data for you to analyze actually. Here we have a different version which is used, the reference is already given. So are you happy with the extracted version? Point number one, as a clinician who has read the paper, that's the point which I want to ask you.
It is actually the new statistical methodology, and for the first time actually I got acquainted with this research methodology, so I'm not really not very well versed about this than the conventional meta-analysis, But since it has come from the very prestigious institute by the very experienced researchers, so I believe that even we need that the time has come that we need to embrace the new statistical method using these tools.
So the point is, because it has come from TMH and the authors are very distinguished, I would take it on the face value. Is that what you're saying, Dr. Bhakna? Dr. Nancy?
Yes, I think looking at their record in the past, we need to embrace the
Come to
new
that.
statistical methods.
Dr. Nancy, what is your take on it?
So, Dr. Sahu, when actually the first time Dr. Sudeep did publish this, I tried to look up some of the statistical articles. And what I understood, at least from whatever I'd read, this seems to be a reasonably good method. I don't think you can really point a finger and say this is a wrong way. There is enough and more literature to say that both the methods would probably be correlating almost equally. Of course, if you have the exact patient details, it is probably a little bit more confidence, but the method seems pretty correct. And I don't think I have an issue with the method as such it has been done.
You are there, sir?
Sorry?
Kanan has not joined. Kanan has not joined.
So we'll just exclude him and we'll go to Seema. Seema, so the point that is being here is the extracted version only works very accurately if you have the curves, Kaplan-Meier curves with you. And if you don't have the curves, then the problem really starts. And you need a very good statistician. And definitely the IPD extracted version gives quite a bit of confidence. And the events are really matching to what the real data is. Dr. Seema, do you find any problem with this version?
So I would like to add here that we have done this method 3 times. And first time when we did in the meta-analysis where duration of trastuzumab was looked at, it took us long time because it took time to expertise and to understand the way the data is extracted. So you are correct that this extracted method can be applied only when the survival curves are there. And along with the survival curve, we also need the number at risk that should be available. Only then we can extract the data. And when we extract the data, we look at various parameters just to make sure that what we have extracted actually matches with the individual actual data. For this, we look at the total number of events that happened in each arm. We looked at the median PFS. We look at the proportion surviving if this is reported at 1 year, 2 year, or 3 year. We also look at we also recalculate the hazard ratio as well as the 95% confidence interval. Everything should match. And we, even in the supplementary appendix, if you read it in detail, we have given the number of extracted events as well as which has been published. And most of them was matching accurately well, except for 1 or 2 events, which were either less or more. And this is across the Parikh meta-analysis also, as well as the trastuzumab paper also. Even the trastuzumab, one more thing which I would like to add here, that the trastuzumab individual patient meta-analysis is also being published by Helen et al. And their hazard ratios as well as the outcome matches exactly with our paper, which is by the extracted method. So which gives us confidence that the way we are extracting the data and the way we are analyzing it is actually equivalent to the conventional way. The extracted version has an advantage that it can be done rapidly because we do not have to depend upon other authors to provide us the data. All the authors may not be willing to provide their raw data.
As I get it, that this is nearly the way how you can do it in a much more faster way. And you can do it without the collaboration and getting the data and the problem that happens with multiple authors coming in and whether they agree to the conclusion or not, the lot of the difficulties that happen. And this is way shorter than the conventional way. That's what I get it. But the point is you need those time points. You need the survival curve. That's a must. Without the survival curves, this cannot be done. That's what it comes out. So is it, Seema, that the aggregate or the trial level analysis which really we have been doing along, and that's the more common way of the meta-analysis, which we see a lot of them coming from China nowadays. So is it that when I have a trial level analysis and I have a individual patient data analysis, maybe the extracted version at this point, so can we tell that except for the absolute benefit, Dr. Sudeep spoke about that is you get to know the quantum of benefit. Let's say 45 versus 17 months that you see in a BRCA positive patient. So that is the absolute benefit which a patient can better understand. That is the best benefit of these type. In a trial level, you get more of a hazards ratio. Is that the main difference, or do you find there is some other difference between this trial level analysis and the extractive version?
Yeah, so one difference which you have already alluded to, that there's the difference between the trial level as well as the IPD or the extracted meta-analysis. Another difference is that the subgroup data and the subgroup analysis is much more better in the extracted version. As Dr. Gupta has already explained in detail how we combined the data and we made our subgroup analysis more powerful. That is not possible in a trial level analysis.
Basically, to everyone here, so the conventional, the individual patient data is still, I think, would be, and if you look at the paper which Dr. Sudeep and Dr. Seema and the other authors have written, they have written in one paragraph that that we do agree there have been limitations because we lack the whole raw data. And there's a beautiful paragraph at the end of the article, and that is accepted by the authors, because if once you get the raw data, you can really get the scores of HRD probably for every patient. They could have done the HRD analysis probably for 25 to 43, or maybe for 42, or maybe 63. Seema, I think that would have been a much more robust way, because you do mention in your trial about the HRD status that yes, we believe that the HRD data and the cutoff should be more defined, and we need authors to come in and put a thing so that every patient who can benefit from the PARK would benefit. Do you think the raw data would have provided us that thing in your data?
Yeah, that would have definitely helped, because as you have mentioned, the HRD cutoff are variable. Some papers use 63, some used 42, some used 33. Though in this meta-analysis, only 2 HRD cutoffs were used, 33 and 42. Only Valia trial used 33, and rest of the 2 trials used 42 as a cutoff. So, I mean, this heterogeneity with respect to the HRD positive would have been eliminated if we had an access to the raw data, and if we could rerun the HRD testing in all the samples.
Got this up as the first slide is, when we look at this data and I looked at the meta-analysis, I read the meta-analysis, something which I knew all along for 4 or 5 years. We have been looking at the data across. I think we need to also look how the data is run, how they did the meta-analysis. That's why I put this slide across. Anyone, including Dr. Amish, has any question, or Dr. Purvish sir, then I'll move on to the next one.
Sahoo, I just wanted to know, did the authors write to all of them, make an attempt to get the raw data before going to conclusion they may not share? Means, was an attempt made, or from before even Sudeep? It was conceived.
So, 2 things I'll answer. I had a discussion with Dr. Sudeep yesterday also. They took, even with this time, they took 1.5 to 2 years. And they to have this publication on, they did not try to do that. If I'm right, Seema can back me, but they got a good congratulatory message from most of the publication authors of all the 5 trials which they put in. Seema, is it right?
Yeah, absolutely correct.
Okay. So now I'll come on and move into Dr. Somsekhar, as you yourself pitched into the battlefield. So can you just tell me the weaknesses, what you find for the paper which we are going to discuss? The weaknesses and strengths, what you feel are the weakness and the strength for this, why I should not accept it and why I should accept this meta-analysis.
Yeah, as actually, if you read the last part of this particular topic, the authors have actually very nicely also told what could be their limitation. Now we have primarily based this whole data based on the 3 major trials, the Prima and the Paloma 1 and Vilia. But if you look at
5 trials, we have the 5 trials. We have 5 trials now.
Yeah, and unfortunately, if you look at there is a lot of heterogeneity in all these trials. Like the Prima trial excluded the stage 3, and then in one trial there was a bevacizumab used as a maintenance, and then while the other 3 studies actually use PARK maintenance at the end of the chemotherapy. And then also the most important thing is a 3-year and 2-year thing. So the thing is, it is not, even though the paper statistic model is fantastic, the available thing particular is heterogeneous and different set of patients treatment was also different. Some used bevacizumab. So the whole thing to finally arrive at, because here there is no OS data, it's all based on the PFS. So based on this whole thing on one-sided long rank test, that's one of the weakness. But we always say that, the statistics is only as good as the data that is provided, and the data is this particular trial. So I would say that this is one of the main weakness which we have. And in one of the trial which actually clubbed everything, like when you looked at the HRD positive negative, the platinum sensitive first line. So I say that the same subset of patients were not used in all the trials. Same endpoints were not used in all the trials. And
something which you're speaking of.
So this is one of the things which is the main weakness in this. Having said that, with the available particular data, the statistic model is quite robust. It really answered what it looked at, HRD negative versus positive, since all the trial had a very huge difference between in the PFS, so they could arrive at this particular strength. So I would say that this is one of the weakness and strength of this trial.
Okay, Dr. Prashant Ganeshan, any points which you want to add on to the weakness and strength?
That's it. I just added this.
Dr. Prashant Ganeshan, is there?
Thank you, Dr. Sahoo. I think Dr. Somsekhar covered everything. I don't want to add anything more. The paper is very well written. I think it's been already discussed quite extensively in the interview with Dr. Gupta also. So I think it is. I have nothing to specifically point out beyond what Dr. Somsekhar highlighted. It's mainly with regard to the heterogeneity of the studies which were put in, but we can do nothing about it. That's the way the things are.
Dr. Vatna, you raised your hand. Dr. Vatna, your hand is raised.
Just want to add extra point what Dr. Somsekhar has said, that in Paula 1, 20% of the patient, we do not have the data for HRD, and 10% in Velia. So it makes a good number of the patients whom we did not have the HRD data.
If I'm not wrong, the variability, the heterogeneity is all us alluding to. You did address that at this point, to the maximum possible, what was statistically possible. Am I right on that part?
Yeah. Even we excluded the patient where HRD status was unknown. We did not include those patients in the analysis.
So my point I want to make is probably when there's a lot of heterogeneity in the criteria, we cannot do much about it. The trials are done that way. The duration of path was also very, very different. Was 3 years in one of them, was 2 years in the rest. But it makes in an individual patient analysis, the benefit is you can really segregate out and really can balance it. But I have a different question to Dr. Seema. What did you do about the unadjusted analysis? Because when you do a paper like this, you cannot adjust anything. And when we look at the trial level thing and in a particular trial, you do find the things adjusted and then the hazards ratio do change. So do you think this is a weakness for the study? Although you did mention about this and you did tell that it did not make a difference. What is your take on it? Will this matter when such more papers is going to come out in the future?
Yeah, so I mean, the data which we combined after extracting from all the 5 trials was not adjusted for various covariates like response to chemotherapy, whether the patient has complete response or partial response, whether there was residual disease or not. So all these adjustments could not be possible in the combined the data which we combined after extracting. Whereas individual trials, they adjusted the hazard ratio as per various covariates defined for each trial, and we did find the difference when we extracted data from individual trials. The hazard ratio was not matching, though the number of events were absolutely matching. This is when we found out that those were adjusted one and ours is not adjusted one. So this is the weakness of our analysis, which we have also mentioned in the discussion.
Yeah, I think now we have to start knowing this extracted way of the IPD analysis, and this is probably the adjusted analysis. If you look at the paper, they've mentioned actually a paragraph about it, and the co-variables, when they're not adjusted across both the arms, that the hazards can be different, and that has happened. But what Seema is pointing out is they made sure the number of events that happened across each timeline were nearly matching to the original papers. That's what she meant. And that's where the authenticity really comes in. The strength, I'll be very quick. The accuracy of events is really there, and Dr. Vamsi spoke about it in his initial comments, that if you look at the reference which they took, the accuracy of events is something that really matches. So I'll move on. And this is the heterogeneity among the studies. The Prima, if you look at it, did not take stage 3. They had to be nil residual disease. There were 3 years of PARP. The rest was 2 years. The Paula was Web and PARP. All of us know that. The Velia is PARP with chemotherapy, which Dr. Sudeep spoke. Randomization took before chemotherapy in this, except others was after. The HRD in here was 33 and more. Solo, only the BRCA positive was taken. So now comes the real issue where I really want the clinicians to come in. Dr. Prasad Narayan to come in, and when you do your practice, do you do HRD or you do HRR, or do you do a LOH, or do you still go with only the BRCA as Dr. Sudeep?
So in the order of what you have written, in that preference we would say, I mean, if HRD is possible, if an HRD test can be done, with the present scenario, I would prefer to get an HRD done for all.
I'll stop you here and tell that, are you confident about the Indian labs which are doing HRD? Number one. Number two, are you sure of any lab which has a data validated?
I am not sure about the data validated lab, but reasonably confident with the reports of HRD from Indian lab. I don't see any reason why we should say, because if you see these 3 random.
Why I brought this in, Dr. Prasad, is that they have a value cutoff of 50.
Right.
Where this value did jump off to, I want to know that from all the panelists. Look at the 42, which was there actually with the myriad. It's actually the 5th percentile of the whole data. That's why the 42 data number comes in actually. And I don't know why actually the 50 comes in for some of the Indian labs. Anyone in the panel wants to answer that? After Prasad finishes, please come in. Dr. Prasad, I want you to. Why not HRR? Because Amish told HRR. Right. He wants to do HRR. Why not HRR? Vamsi, I spoke in the morning, he also does HRR. Why don't you prefer HRR, and why do you want to go for HRD?
Why I don't prefer, I mean, if you, when you're talking about this same meta-analysis, and the outcome of this is that if you have an HRD, I mean, if one thing which we can take from this meta-analysis, the weakness itself is the strength actually. We could get clear message that if it is a HRD negative, this patient will not benefit with that is one take home. So if you have a test which can tell us that, and the duration of treatment is like 2 years, 3 years of PARP inhibitor, if we can say that with confidence that if HRD comes negative, regardless of what other test is there, and you can say that this patient will not benefit with an adjuvant therapy of 2 year, 3 year, I would go with that test.
So you would be still preferring a reliable HRD is what I'm getting from you. HRR, you're still not very confident enough. Dr. Ajay Yadav, your take on that? And anyone in the panel doing LOH?
I agree with Dr. Prasad. I will do HRD.
Okay. So you have something to defend now. HRD versus HRR. HRR is your preferred test. Why?
Okay. So context. If you ask me, am I happy with the HRD that we have here? I have the same doubts that you raised. Is it validated? If yes, how? Why did we get 50? I don't know the answer. I have asked this to the lab, and I was just told that no, we have internally validated it. It is not a published data. I am not fully 100% where they got this from. To be honest, the happiest I feel is if I get a BRCA1 and BRCA2, because that's the one thing I'm 100% sure is right. This HRR panel, you know, this is just what I was typing in the chat box as well. The HRR panel, I am not aware of a specific ovarian trial that has looked at HRR, these 15 genes that we are testing. You know, the Indian labs test this 15 genes out of prostate. But when you ask for a HRR panel in any lab in India, they will do the same 15 genes and tell you HRR positive. So,
so to make things complicated for you and probably easy for us, 50. Look at the Paula one. The HRR thing when they looked at was a mutation that they looked at for the HRR, the mutation part was actually negative. It was not predictive for a PARP inhibitor response or the benefit. So if you have a large trial like Paula 1, which is one of the trials which is taken in and which did not find HRR to be a beneficial data, why would you spend so much of money on a PARP inhibitor with the HRR mutations alone?
Correct. So that's exactly what I'm saying. We don't know. The answer is you don't know. So if I get a BRCA1, BRCA2, I'm very happy. I know I'm on the right path. This
Everyone is
HRD
happy.
other genes, I really don't know what I'm doing. So that's one reason why HRD is probably a better option. You trust the lab and say that, okay, boss, you guys have done the right job. 50 is what you're saying. Let's use 50. I don't have the data to back it up, but that's probably what I would go with.
HRD versus HRR. And we have conflicting results from HRR. Very few retrospective data from, let's say, the initial olaparib trial showing that that could be beneficial. But most of the prospective trials showing that even the Apollo one was the major one. Even the ESMO consensus guidelines on this testing has also shown that there is an issue with the mutations with that there. It has not shown to be a predictive point as far as HRR mutations, the gene mutation is concerned. What is your take on this?
Yeah, in fact, there is one more paper which looked at the HRR, a correlation between HRR and HRD. And it was done only in high-grade serous ovarian cancer. And it was seen that if HRR is positive due to some other mutation other than BRCA1 and BRCA2, it does not correlate with HR positivity. And even as per the POLA results, the HRR positivity was not predictive of PARP inhibitor benefit. So overall, I would not favor HRR. I would, if I have to choose, I will choose HRD.
Okay. Anyone in the panel wants to say something, because this is something very important.
Tarini,
Boss.
Can I say, I think I'm reading different textbooks than what people are talking. HRR is an abnormality, while HRD is the consequence of those abnormality. If I have understood the concept clearly. The very fact this meta-analysis showed that PARP inhibitor work in HRD positive minus BRCA1, BRCA2, in my understanding, it is very crystal clear that there are other mutations also which end up causing these, accumulation of telomeres and chromosomal instability. And as a result, you have HRD score. So I feel why HRD is important, because even though there can be some abnormality, it may not result into HRD. I think that is the concept which I have understood, and that is very important according to me to understand.
Okay, the point what people are trying to make out, and probably the articles are trying to make out, is that HRR defines, as Dr. Vamsi told, around 13 to 15, and there are multiple panels. Some have extra additional 5, some have 13, some have 15. And what is happening when you look at the mutations as such, there are some mutations in literature which probably has a predictive value for PARP, some not. But as a whole, when they combine together, when you look at the HRR, when they constitute a part of the HRD, they do find benefits. But when you look at individual mutations as such, the benefit as such on a prospective trial is lacking. That's what every panelist is speaking about. So that the prospective trials are looked into 2 things only. That is, one is the HRD. That has been the most common. And the rucaparib trials have used always the LOH score. And that they've used more than 16, equal to 16 as a score. But if you do the foundation, actually they also do a NGS, which also gives you the mutation part also of the genes, which people can then correlate. But that is what people are wanting to say. Dr. Ganeshan, you have put up your hand. You want to say something on this?
Yeah, just to add to that discussion of LOH versus HRD, as you know, LOH is primarily coming from the foundation, because that is their primary criteria. The other one uses 3 criteria to define. So as we know, there's no direct comparison except for 1 or 2 studies where they have taken a data set of patients and tried to run both these and see what happens. And from those papers, it seems that 10 to 15% of patients who are recognized as HRD positive by the Myriad test are actually not recognized by the foundation test. So the foundation test seems to miss out probably 10 to 15% of HRD positive patients. So that is something to keep in mind, because especially when we are talking in terms of the rucaparib trials running the foundation test primarily. So if you want to choose between these 2 for an individual patient, if at all we have an access to these tests, I would prefer probably the Myriad one at this point of time, but that's purely based on this very preliminary reads.
Yeah, also one thing which I told, I will repeat, that the LOH, when you send it to the foundation, they do the mutational, the NGS also, which you get the mutation to correlate with, and that's a part of what the HRR is all about. So I'll move on.
But that's not included in the definition of their
No, it is not. As per definition of rucaparib, it was initially aerial 2 was 14% or more, then it came to 16%.
16.
So that's it. Yeah, 16. Now it's 16. Aerial 3 put on 16. So germline versus somatic. Dr. Sudeep told about that, the testing part. If you look at, you can use both. The responses with the aerial trials have shown to be equal. But this is something interesting which I found out. And if you look at the ESMO publication of Annals of Oncology, they have actually put up a very different sequence. And that is something which I want to discuss the panel. Very short question. And Dr. Ajay, you can come in first, and then Dr. Ajay Bafna can come in later on. Ajay Yadav first. So here, if you look at this data set, and most of them are the French cohort, they have one patient who was germline positive and the somatic mutation was negative, which you normally don't see. You have more of the somatic, which you add on to 5 to 7% apart from the germline. So this article, more so of a consensus article in the Annals last year published, put up as that you do the germline, you do the somatic, and you do the HRD. This is how they have sequenced, and you do all the three as a must. So, Dr. Ajay, do you do the same way, that if the labs are reliable, I will do the germline BRCA, I'll do the somatic BRCA, and then I'll do also the HRD?
No, sir. If germline is positive, then we don't do MRD.
Okay, you don't do MRD. And if the germline is negative, you do the somatic and then the MRD. That's the sequence.
Yes, sir. Exactly.
Okay. So I think most of us do agree. And if there's any more controversy, no controversy, I'll move on. What to order is already discussed. Very beautiful thing of breast versus ovary. If someone is really interested, the HRD status when came in were combined tissues of both breast and ovary. The breast, the HRD is usually lower. And the ovary, the HRD status is higher. That's why there's also a point that comes in. Can 63 be the cutoff? That's for some other day. So my question was for HRR, Dr. Amish, I would like to put this slides for you. Are all genetic instability changes the same? If you look at it, this is the paper I think which Seema was spoke of, and look at this part of it. And look at this HRD score and the HRR mutation. And this HRD score goes from score 8 to 104. The blue one is the lower HRD score. And if you look at it, the HRR are also expressing here also. So the point that comes in is that the HRR mutations can be seen across the panel of HRD, even in the low HRD as low as 8. So that is something that really is something we need to talk about very, very clearly, and we need to look very, very carefully when looking at HRR. The number 2 that comes in the paper that comes in is that the CHEK1 and the PTEN are homologous deletions have high HRD scores. They also have high LOH scores. Other than that, all HRR mutations that come in do not have high LOH score, which I think Dr. Prashant, you spoke about that. So this is actually something that does not match actually with the HRR and even the HRD. So I'll move on. And this is the question which I'll ask to Dr. Ajay Bafna. Can platinum sensitivity be a poor person's HRD? Can we consider the platinum sensitivity to be a poor man's HRD? Dr. Ajay. Dr. Ajay Bafna. Is there? Dr. Sensitive?
He's muted. He's speaking, but he's muted actually.
Dr. Bafna, can you
platinum, yeah, so platinum sensitivity is a surrogate marker for HRD positivity.
Mm-hmm.
So it can be very well used, as a surrogate marker.
So you agree that if I do not have a reliable lab and my platinum sensitivity is there, I have a BRCA negative, still you would be more inclined towards giving a PAP?
Yes.
You would. So that's a commitment coming on. Dr. Amish is shouting at us, no. I'll come down to and show data to Dr. Amish.
When we are looking at a drug which is not, it's potentially also have a lot of side effects for such a long duration, there is no reason why we cannot do, because all platinum sensitive are not HRD positive, and then there is a group of patients who may not be still benefit. When we're going for such a drug and this should be the baseline, there is no reason why not to do it.
So I totally take your point, but this was a point that has been put up in very reputed journals. So I think that discussion should come in. And we as oncologists love medical oncology. At least you are a surgical oncologist. You like to derive fun out of your intraperitoneal chemotherapies and HIPEC. So we would love to do with our PARP inhibitors.
No, I'll tell when I as a surgeon, when I really interact with most of the medical ones say my job is just to give some platinum, prove it is sensitive, and I can just switch on to this. So
I'll show a data, which is a phase 2 data and also some phase 3 data, and let's see what it is. Dr. Prasad, yes, no?
No. And
Dr. Vamsi?
yeah.
No, your question is, do I believe that platinum sensitivity is good enough as HRD? No. HRD is HRD. I take Dr. Som's point, you should test for it. No reason not to test for it.
That is the best way. But if you look at the trial, there's a Quadra trial. I was not aware of the trial, but there is a phase 2 data, which is the niraparib monotherapy in multiply failed ovarian cancer. This is that there are patients who out of them only 30% are platinum sensitive, most of them platinum refractory. And if you look at it, the responses that come with the HRD negative, look at the last block. The HRD negative, this was only with rucaparib. This was only with rucaparib. So the patients who were HRD negative or unknown and BRCA negative, look at the platinum sensitive in this subset of patients, they still responded to the same tune to the BRCA positive one. Dr. Amish, any comments on this? And this has been also shown in the Ariel trial and also in the Prima trial to some extent.
Can I comment on that?
So there is, yes, Dr. Ganesan, please go ahead.
Yeah.
Please go ahead.
So this, especially this question about this HRD negative or unknown showing a very significant benefit. So if there was a correspondence which was written for the Athena trial, because a similar data was there from the Athena trial also, because the HRD unknown had a very good benefit in that trial. So the reply to that comment from the authors were that this particular subgroup was enriched for patients who were very sensitive to platinum. I'll tell you how that happened. Because for testing, you need the tissue which comes from the surgery. So these patients who undergo neoadjuvant chemotherapy, and at the time of surgery, if they have a very good response, there is very little tumor tissue left in that specimen. So most of these tumor tissue specimens end up being labeled as HRD unknown. And when these patients get the drug, they do very well because they are actually a population of HRD positive patients who have responded very well. And it's because of this reason that this gets enriched and this population looks like they are doing too well, actually. So looking at this and saying that HRD negative also benefits is actually not right. They're actually HRD positive patients.
I'll stop it here because the panel discussion is a very limited time. But I think I'm not telling that we should stop doing HRD. I'm not telling that, but it is a point which you can ponder of as a potential patient who are more likely to be HRD positive. But the point here that comes out is, in spite of that, platinum sensitivity is a good marker which probably can push towards a PARP inhibitor for people who believe in that PARP is for all comers. In that, I think that selection can happen, and they should look at the last platinum sensitivity to the last one. That's the only point which I wanted to make. I'm nowhere telling that this should replace. Dr. Amish, you wanted to say something. I'll move on.
HRD positive predicts platinum sensitivity, but every platinum sensitivity does not predict HRD positivity. That is what I wanted to say, Sahoo. You can move forward.
Okay. So now I come down to a very important thing of when do we need to sample? When do we need to sample, Dr. Vamsi? Most of the trials have told baseline. And if you do a baseline HRD, if you look at the methylation of BRCA and some other genes, it is also adds to the HRD score. So do you think that the best time to do it is a baseline, or does chemotherapy change this HRD status?
So chemotherapy might change it. I'm not very sure the right answer, but obviously it's good to do it at the baseline. The challenge in India, at least, is most of our patients will end up getting neoadjuvant chemo. And then, you are anyways at pre-diagnosis, most of us don't do a biopsy. We might be just happy with any ascitic tapping and all. So that's a practical issue.
I'm only dealing with the first line only because first line neoadjuvant was allowed. And when you have a chemotherapy, actually, there is a paper, there are a lot of papers actually telling that the methylation is demethylated, and that could be a change in the HRD status. And that's why first time I saw in the consensus paper of the European guideline that they have preferred two times of doing it. They're not telling that you should do. They tell basically baseline is the best time. But even some have told post chemotherapy also you can do the HRD. You might get a difference. I'm not telling you to repeat it twice, but still the paper maintains the biopsy at the baseline of the baseline is the best way. But remember that this epigenetic changes, especially methylation, can change. And that is something we need to remember very, very clearly. I'm going to jump to the last part of 10 minutes. Dr. Prashant Ganeshan, look at the D slide. We have been looking at the p-value always, and look at the D which Dr. Amish showed. Well, I'm showing it a little different, which is the updated data from the authors. Here they included the 5th trial, Dr. Vamsi. That's why I told there are 5 trials. They use the rucaparib data. So now this updated data of the TMH trial, meta-analysis has 5 trials actually now. So now this the rucaparib data is showing a HR of 0.84, and the p-value is 0.03. The hazards is the confidence interval is not wide now. Dr. Amish, you showed a data which was the HR was 0.9, the p-value was insignificant, and the confidence interval was wide. So now with this data, which as per us, we always look at statistics, and then it shows that even in the HRD negative and the BRCA negative, these patients do benefit from a PARP. What is your take on this, Dr. Prashant?
So I think this was already mentioned by Dr. Sudeep also. It's not like it does not benefit. It's the quantum of benefit which is clinically relevant for us. So here is going to be only 2 months of benefit. So are we going to invest on a therapy which is quite potentially, which has got significant toxicity, significant financial commitment? Are we going to commit on something like that for something like a 2-month benefit? We're not saying there is no benefit. There is a very small benefit.
Month benefit.
There.
So 3.5 month benefit on the PFS with the 50 months of survival data of a, so in a ovarian cancer does not look significant.
Does not seem significant. Yeah.
Okay. Dr. Narayan, can you tell me now as medical oncologist, what Amish told me was insignificant p-value. After the rucaparib data is added to this meta-analysis, the p-value becomes significant. So should I be discussing this with the patient now?
This, I think, if it is HRD negative, we should
consider the D curve
inhibitor. Yes.
So do you not even consider discussing with the patient?
I will not give PARP inhibitor maintenance in this patient.
Okay, now there is a meta-analysis level of the evidence showing that even in this subset, there is a statistically significant value. What do you make of it? Dr. Sen? Can you take this for us? It is your paper. The initial, when you published, has an insignificant p-value. The confidence interval was wide. Now the data changes. What do you make of it?
Yeah, so if you look at pure statistics, since the numbers were added, the total number of patients in HRD negative also increased. So that's why the hazard ratio also reduced a bit, and the confidence interval has also narrowed down as compared to the first paper. But we have to interpret the analysis with respect to the context of the disease. Even with the improvement in hazard rate, the absolute improvement in median PFS is by only 3 months. So that is why in first line setting, 3 months improvement in PFS is not clinically meaningful.
Okay. So the point that is coming up is, Dr. Seema, Dr. Bafna, you have to, last word goes to you on this one, and then I will ask Dr. Amish to come in. Dr. Bafna, we have been always reading about p-values, significant. The first paper told it was not significant. Now the rucaparib data makes it significant.
So the
what
paper, so the paper clearly mentions that it was the gradient of PFS, which was, matter to these patients, which was not present in the D subgroup. So the progression-free survival of such a low magnitude not translating into the benefit to these patients, I think currently for the D subgroup, we should refrain from using the PARP inhibitors.
The answer is same, or do I look into that the data which was added, the rucaparib trial is something I will criticize?
Rucaparib trial, Tarini, 4:1 randomized. Look at the numbers of placebo. Matlab, how can you decipher? And I think Sudeep in his interview gave a very good perspective, and Seema Gulia also mentioned the same. I would look at the clinical absolute benefit rather than just looking at HR value and P value, Tarini, before I decide.
So I brought this up very clearly because this data will be utilized to people to justify when they start giving it, because you have a significant value here. The point that all of us want to make is the quantum of benefit that comes out is less. But as some of us have refrained from discussing the patient, I will myself, on my personal opinion, would like to discuss it, because let the patient decide for himself or herself that whether he or she wants to take this or not. Because I think the data is discussed, but we need to also, definitely. And we also need to discuss the quantum is very, very less. Second point is, I always believe with the rucaparib trial 4:1, and it was only 200 odd patients in this HRD negative 189 versus 50. That was the randomization that went in. Is something that really is something that I am not very comfortable with. It is too imbalanced as a trial. The 4:1 arm is too imbalanced. That's my point of it. That is the reason I'm little skeptical. I'll just end my thing. Before that, I would like to go into, even niraparib is approved for all comers. And I would like to bring this data to this part of it. Look at the niraparib data and look at the homologous recombinant proficiency. Dr. Ramsey, look at the niraparib, and the subset which should not benefit has a hazards of around 0.68. What do you make of this niraparib data for the patient whom we do not want to use a PAP?
So again, look at the thing in BRCA, you have 0.40. In no BRCA, but HRD,
benefit.
0.5. No. So my point being that the benefit is there in those groups. Here you're 0.68 with confidence intervals all the way from 0.49 to 0.94. I mean, okay, I cannot explain this, but in the weight of evidence that is there, I would still not use it for a HR coefficient. Then the whole discussion is over. You can just stop talking. And again, like what Seema was saying, you may have this hazard ratio HR positive, but what is the clinical benefit in that? The previous slide you said 15.4% versus 14.6%. That's 0.8% at 3 year. I mean, I don't think that's clinically relevant at all. So I stick to my guns. I would not use in a HR coefficient.
I think this data has to be discussed, because this is where the proponents of PAP in this subset are going to bring these two data up and telling, see, you talk of statistics, we have statistics in favor of this. I think the quantum of benefit, the toxicity which Dr. Bafna spoke about, and if you look at the meta-analysis, you have hematotoxicity all across, grade 3 toxicity more towards PAP for 2 to 3 years duration with rare chances of MDS. I think the benefit and the cost, it feels that the benefit is little lesser and the loss is much more.
I would favor the statistics. I wouldn't favor the drug or the clinical benefit.
To Dr. Vamsi, one thing. When did you give the drug for DEL19, the lung cancer, afatinib?
We did it at a time when we did not have a better drug.
It was afatinib data. It was nothing, less than a month difference.
True.
And all of us went gaga over afatinib to be a choice for DEL19. So are we getting mature? Are we learning are we good now at looking at the data at a holistic way or not jumping at the p-values only?
I agree with that, because Dr. Sahoo, now if we get an L858R also, we are not jumping ourselves to give osimertinib as well. We know that there are signs which we need to be aware of. So in that context, I don't think at this point HR proficient, I mean, we can always say that, look, there is some data on it, but I wouldn't put my neck out and give it.
Okay. Anyone want to say something? Dr. Somsekhar, you want to say something in the last before I go to conclusion slides? No? Anyone? No. Okay. So I'll conclude. You look at the individual patient data, the conventional way still looks to me the best way for a meta-analysis. The point is that you have difficulties in taking this people across. You have to get the authors online, you have to get the raw data, you have to let them agree to the conclusions, and it's a difficult job. It normally takes 4 to 5 years sometimes to put a meta-analysis into the public domain, and by the time treatments might change also. The extracted is accurate, that's done case, but has limitations which we spoke of, but it is much more faster, cost effective, and it takes lesser time, lesser than 50% of what a conventional way we do it. And apart from that, because the data is in public domain, you do not need the consent of the other authors to do that. HRD, what would be the best cutoff? 42, 33, some people are putting as 63. I think that the data today is that when you look at a drug, you do it drug wise, but 42 is more consensus, but we are gradually going to 33. But Dr. Sudeep told to me a very good thing. Probably we should look at HRD, and more trialists should look at it. And we should not let any one of the patients miss out on this lovely drug PARP if they can afford it. The LOH versus HRD, they have been drug-based development. Gupta looks more of an LOH, HRD with the other drugs. That's point number, last point. PARP inhibitors definitely have a role in the first line, that's for sure. Should it be for all comers? I have my doubts. So Dr. Amish, I may have showed the slide, put the argument forward, but I do believe that for HRD negative, I would not do to my patients, but I'll be very careful for legal issues. I want Dr. Parikh to say on something on that. Should we be at least discussing with the patient, to a few of the panelists, refrain from even doing that? And I will probably do it to keep me safe in the days to come forward. The best way to discuss is with the patient with all this aspect, and toxicity is to be kept in mind. Dr. Ajay, you spoke about it, and I'm sure PARP inhibitors are a toxic drug, and the patient will have some toxicity, at least in the initial part.
And
So
financial
that,
toxicity as well, na?
PARP inhibitors,
Financial
yeah,
toxicity.
it is only patients who come to you can afford it, boss.
Yeah.
Not people come to me. So with that, I stop here, and thank you everyone for giving the opportunity.
That was wonderful, Dr. Sahoo. You really played the role of devil's advocate very nicely. And since you have asked me one question, I must say that I've already answered it in the chat box, but I will repeat it. That if I'm not convinced of anything like 2 to 3 months benefit, I would not recommend it directly to the patient. But as Sahoo mentioned, I would clearly document that I have discussed with the patient. Because in courts, what is documented is proven, and what is not documented is not proven. So thanks, Sahoo. Thanks all the panelists. I think this was a very tough panel discussion, and some really insightful points have come out, especially with the HRR and HRD. And now it is my duty to invite our expert comments from none other than Dr. T. Raja. He, as you all know, is a stalwart that is at the forefront of personalized medicine and genetic characterization, and how to interpret that beyond what is standard of care. And we are also discussing how we can write some publication on guidelines to treat patients beyond standard of care. So over to Dr. Raja for his expert conclusions and the way forward.
Thank you, sir. Let me try to see whether I don't know. There is a bit of a confusion here with my system. You are able to hear me, but I don't think you are able to see my slides, correct?
Correct.
Not yet, sir. Not yet, sir.
We can hear you.
Let me see, because it's my apologies. I should have tested this out. I changed my computer, but I think I'm in a complete trouble. Okay. Let me see what.
Or we can just hear you.
Yeah, sorry. That's what we should do. I'm so sorry. It should not.
No problem. No problem.
Yeah. So first of all, I really want to congratulate the authors. Dr. C. Magulia, the first author, she was here, and Dr. statistician, and the entire team, Dr. Ghosh and Dr. Rath, Amita, and Dr. Sudeep Gupta, and the program directors, Dr. Amish, Vora, and Dr. Purvish, selecting this, which is very, very important. How do you clinically context a very, very mathematical and statistical kind of paper, so that every clinician should finally decide what to do with this. So it's very, very important. So then, what do I take out of this particular discussion is that the original paper on the corresponds, very elegant conclusions. The conclusion, let me just reiterate for the sake of the entire audience, that among newly diagnosed ovarian cancer patients, PARP inhibitor maintenance therapy significantly improves the PFS in those with germline and or somatic BRCA and or HRD positive tumor, but not in those with HRD negative tumor. So very, 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 very simple and elegant conclusion. That's the beauty of this entire meta-analysis. And, the individual parts of the meta-analysis was discussed in detail, but if you have germline or the somatic BRCA mutation, you have a hazard ratio of 0.38. And if you have a HRD positive, including BRCA mutated, you have a hazard ratio of 0.48. And if you have a HRD positive, which excluded BRCA mutation, you have a hazard ratio of 0.51. And then you have the D subgroup, which you could finally get in the correspondence. You have a HRD ratio of 0.9, which changed to 0.84, as Dr. Sahoo beautifully pointed out. And then you have the forest plot. We all know that meta-analysis is an integral part of evidence-based medicine, and we know the traditional methods of meta-analysis, study-level meta-analysis, has its own flaws, and that's what we are trying to, but it's a very high level of evidence. But then among meta-analysis, again, level 2 meta-analysis is of, if you want a meta-analysis, heterogeneous group of trials where you can't really homogenize them, and level 1 kind of meta-analysis is a very homogeneous RCTs or meta-analysis. And I think this paper really reaches level 1 kind of meta-analysis, because IPD is a very special method, and of course there was a discussion in the method of IPD that was used and where they extracted with the software. But I still think that IPD is a very, very essentially the best way to go for meta-analysis, and they need dedicated staff. You can't do it with something like a spare time. You need dedicated staff, you need people to conduct this IPD, and then therefore this method of extraction and software usage is fully justifiable in the real world, when all the caveats were pointed out, that you need to contact the authors, you need to make the raw data available. And so I think the method that was used, to me, is very, very acceptable. And the authors, and Dr. Sudeep Gupta himself in his interview said very clearly that there are some limitations in our analysis, mainly relating to the design characteristics of the included studies, and with respect to the patient eligibilities, treatment characteristics, and statistical considerations. And then again, it was elegantly pointed out that HRD itself is very, very, the cutoffs were very variable, 33, 42, and then Indian labs are now calling 50 as their cutoff. The heterogeneity of these trials were pointed out, but again, Vamsi pointed out that, and Prashant Ganeshan pointed out, that we can't do much about the heterogeneity. That's the whole idea of doing the meta-analysis. And then, we talked about adjusted PFS and unadjusted analysis. That's what Dr. Seema pointed out, but the authors themselves have considered in the paper that the unadjusted analysis, while is a weakness, but it is not clinically impacting. For me, when I have a patient in front of me, and when we have these important data set, I need to decide what to do with my patient. So my comments after listening to the both the interview and also very elegant devil's advocate played by the panel discussion, moderator Dr. Sahoo, and the entire panelists, let me say that I completely agree with the views of the interviewee. I have fine-tuned my own practice ever since Dr. Sudeep Gupta gave that insights about this paper 1 year ago when he gave an interview to Dr. Senthil. I think many of us have listened to that interview, and he did give insights about most of the results of this paper in that interview. From since then, I have fine-tuned my own practice. So my own practice today is that all patients who are diagnosed to have epithelial ovarian cancer first line, who have either germline or somatic or HRD, will be eligible candidates for first line maintenance. And I don't discriminate between the given groups. I do not select by the presenting high risk factors, and I do not select only by platinum sensitivity. And I do not use first line maintenance for anyone with a negative HRD or negative for any of these three indications. In our unit, my own, one of my postgraduates is currently doing a study wherein he is looking at the HRR, and in all patients, epithelial ovarian cancer, HRR, all the panels and the HRD score. And hopefully we will present our own Indian, interpretation of what the HRR and the HRD correlation is, and that will probably have some, inputs into how the clinician can do what they can do. So my take is that it is an elegant paper and excellently written up, and we have a lot of meaningful takeaway from this. And in my opinion, it has refined my practice, and as an expert, that's what I want to pass on to all of you. Thank you all of you for this wonderful opportunity, and thank you organizers.
Thank you
you
so
very
much,
much.
sir.
Go ahead, Amish.
No, sir, I was waiting for you. So now you have to go ahead.
My computer froze for a second, so it took a while for me to connect. But I think Dr. Raja has nicely pointed out what is the practical way that we should move forward in our day-to-day practice. And as you rightly pointed out, he has been following what Sudeep has discussed 1 year ago. And now this is a culmination of more and more data and a better analysis of published data. So it's really good. And I think this is one of the most exceptional oncology beyond the obvious sessions, because everything that we have discussed, including the publications, is done by our colleagues from India. And I think that is a big achievement at an international level. If there was somebody from ASCO committee who was attending this session today, I think he would have found the quality as good, if not better, than any plenary session of ASCO. So that is really wonderful. I thank everybody and hand over to Amish for the final comments before we sign off.
Hey, sir, you have said all. Now we have to wait for the next second Tuesday of February. Right. And we will very soon announce that. I wanted to thank everyone for such an amazing I learned so much out of all these OBTOs, I can't tell you. And I wanted to congratulate Tarini for doing such a wonderful job. Raja sir is always awesome. And I always want to be his student whenever the opportunity comes, provided he selects me as a student. Thank you so much, sir.
And we thank our sponsors, AstraZeneca, for making this session possible. Thank you very much.
Thank you. Thank you.
We can sign off, and please have a wonderful rest of the evening.